We will call to order the Tuesday, March 12th, the year 2024. This is our House Health Subcommittee. Ms. Adams, if you could please call the roll.
Representative Hicks. Jernigan. Leatherwood. Martin. Mitchell. Sherrill. Terry. Williams. Chairman Hawk.
I'm here.
You have a quorum.
Thank you. Chair detects quorum. We are in another one of those times of session where members are coming and going quite a bit, presenting bills in other committees, as well as folks coming in from other committees to present bills in here. So we will go as expeditiously as possible. Anyone have any personal orders on the committee? I do have a personal order. We are glad to welcome with us today our doctor of the day. Dr. David Earhart is here, anesthesiologist. Welcome so much. I wish you were an ENT to help me with my allergies that I'm having right now. So forgive me if my voice comes and goes today as the allergy season has fully hit me. My apologies. Seeing nothing to come before the committee, we will begin with our calendar. We have item number 1 on our calendar, House Bill 2897 by Chairman Dr. Kumar. Chairman, you have a motion. You have a second. You are recognized. I think we've got an amendment to your bill.
Thank you, Mr. Chairman. I have barcode 015593.
Drafting code on the amendment is 015593.
Yes, sir.
That's accurate. Let's go ahead and put the amendment on the bill. All those in favor of placing amendment drafting code 015593 on the bill, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. Your bill is amended for description. You're recognized.
Thank you, Mr. Chairman. House Bill 2897 is about healthcare and drug purchasing by patients. Healthcare is complex and it's getting more complex every day. The new wrinkle is that insurers are at this time purchasing certain pharmacy chains as well as PBMs. So in that setting, the insurer can raise the price of the drug they purchase because they're purchasing it from one of their own subsidiaries. And they can pay more, although money remains with them as far as the major conglomerate is concerned. The result of raising the price of a medication is that patients' copays go up. And it is not uncommon for a patient to use their insurance card to purchase a medication that they need. And on the other hand, their copay will be, let us say, $400, and that drug could be available on the free market for $100. And patients do not know that. What this does is the pharmacists have software programs that will tell them the easy or less expensive availability. So this asks the pharmacist to make a reasonable effort instead of shall to find out if the medication is available at a lower price and to inform the patient. It is further complicated by the fact that if a patient was to choose to purchase a drug for $100 rather than pay a $400 copay, that $100 does not count towards their deductible unless they call the company. And we passed a law this last year to that effect. So it's complicated, but again, we're trying to make the best effort to save money for expensive medications to patients. Thank you.
Thank you, Chairman. And I think I heard you in your explanation say this is an encouraging piece of legislation is what we've got there. Thank you. Any questions or comments of the sponsor? Hearing none, you ready to vote? All those in favor of sending House Bill 2897 as amended to full health committee, please signify by saying aye. Any opposed, please say no. The ayes have it. Your bill moves forward.
Thank you, Mr. Chairman and committee.
Thank you, Chairman. We're now ready for item number 2. The request from Chairman Vaughn's office, and correct me, item number 2, House Bill 2011. We've asked to roll this bill for 1 week.
Yes, sir.
All right. Item number 2, House Bill 2011, rolled for 1 week without objection. We are now on item number 3 in our calendars, House Bill 2093. I've got another communication that we may want to roll this bill as well.
Hot off the press, Mr. Chairman.
Hot off the press. We were gonna try to get you going on that one, but the request has been item number 3, House Bill 2093, rolled for 1 week without objection. House Bill 2093 rolled 1 week. We are now on item number 4 on our calendars, House Bill 2308. You have a motion? You have a second. Sir, you are ready to go. Do we have an amendment?
Yes, sir. The amendment is 15053.
All right. Ladies and gentlemen, let's look at this amendment and place it on the bill as we discuss. You have a motion? You have a second. Amendment is drafting code, as the sponsor said, 015053. All those in favor of placing this amendment on the bill, please signify by saying aye. Aye. Any opposed, please say no. Your bill is amended for description. You're recognized, sir.
Thank you, Mr. Chairman. Didn't want you to think I just came down here to roll my bills in person for all 3 of them. Nice to be with you. Current law, as you're aware, prohibits a hospital outpatient clinic from being able to use nurse practitioners to enroll patients into its own clinics that prescribe buprenorphine for substance abuse. And what this means is that these type patients are now held. That means that the patients are held in inpatient rooms of hospitals for longer than they need to be. Because the way the current law is worded, hospitals and their attached outpatient clinics are not able to obtain licensure as an OBOT clinic. This bill would create a new requirement for hospitals who want to use nurse practitioners as part of their opioid abuse clinics that see patients in both the inpatient room and in their attached outpatient clinics. So this is a way to get folks who have substance abuse problems so bad that they wind up inpatient, and this is a stepping stone to get them out, kind of a step-down unit, as it were, for those folks. It ensures that hospitals taking advantage of this exemption must follow the same standards as CMHCs and FQHCs, and ensures that they are capped at the lowest level for the prescription of buprenorphine. So that's the bill, and we're just trying to get folks out of inpatient settings and get them into outpatient clinics, and then moved on in the process.
Thank you, Chairman Vaughn. You've heard the explanation. Any questions or comments? Chairman Terry, you're recognized.
Thank you, Chairman. And my understanding is you worked with the TBI to try to narrow the scope of this. Can you tell us which hospitals this would be narrowed to?
Well, right now, it's the folks that brought me the bill was Vanderbilt.
Okay.
And that would allow them to utilize their facilities in a more efficient way.
Okay. Is this for the amendment for teaching hospitals? Is that your understanding? Yes.
Yes.
Thank you.
I got that. Suddenly it came to me. Yes, of course, teaching hospitals. That's it.
Brilliant answer. I must say, Chairman Vaughn, thank you very much. Any further questions or comments? Question's been called. All those in favor of sending House Bill 2308 as amended to full health committee, please signify by saying aye. Any opposed, please say no. The ayes have it. Your bill moves forward.
Thank you, Mr. Chairman and committee.
Item number 5, I think we've got the request also by Chairman Vaughn to roll this bill 1 week as well.
Yes, sir.
House Bill 2663, item number 5 on your calendar is rolled for 1 week without objection. All right. Item number 6 on our calendar, we had some conversations with the clerk's office, and as this bill had been calendared with this committee, research has shown us that this bill actually belongs in a different subcommittee for the title and the discussion that will happen. So item number 6 has been removed from our calendar. It has been re-referred without objection. We are now on item number 7 on our calendar. Chair Lady Carringer, there she is. All right, Chair Lady Carringer, we're calling up item number 7, House Bill 2358. I think we've got a motion and a second. I think we've got an amendment on your bill as well.
Yes, we do. Thank you, Chairman.
I'm looking at drafting code 015314.
That's correct.
That's accurate. Got a motion? Got a second. Let's go ahead and put the amendment on the bill. All those in favor of placing amendment drafting code 015314 on the bill, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. Your bill is amended and ready for discussion. You're recognized, Chair Lady.
Thank you, Chairman and Committee. This bill is being brought by Tennessee Oncology, which is the largest oncology provider in Tennessee. Tennessee Oncology has its own centralized medically integrated specialty pharmacy called Park Pharmacy that is used to serve all of its 35 clinics in Middle and East Tennessee. Park Pharmacy fills prescriptions for the clinics and delivers the drugs to the clinic by courier. Due to some changes in interpretations and federal guidance by CMS on the Stark Law, around the time the public health emergency ended, medications can no longer be shipped to the patients' homes. With many of Tennessee Oncology patients living in rural areas, sometimes an hour or more away from their nearest oncology clinic, the clinicians would try to anticipate which drug and dose the patient would need and have it waiting for them when they arrived at the clinic for their treatment. And the problem arose in the situation when patients would arrive, and then the oncology or hematology team determined that due to certain changes in the patient's conditions of lab results, the drugs waiting for them was no longer the best and safest treatment for the patient, and a different dose or medication was needed. And under current Tennessee law, the initial medication could no longer be restocked as the drug had technically left the pharmacy and was deemed to be waste, which causes significant financial burden to the healthcare system and practice. Some of these medications have also been part of the recent drug shortages. So along with that, Tennessee Oncology alone had spent more than $1.6 million worth of medications considered waste due to this issue. And so then as the bill has been amended, it would permit the Board of Pharmacy to register mechanical, electronic systems, and cabinets that store, control, and dispense prescription drugs in oncology and hematology clinics, thus effectively acting as the licensed mini outpost of integrated pharmacies. So with that, I also wanted to thank the Board of Pharmacy for helping define and pretty much write this bill in order for us to prevent waste with these very expensive oncology medications. So with that, I would stand for questions and ask for your support of the bill.
Thank you. You have heard the explanation of the bill as amended. Any questions or comments for the sponsor? See, the question has been called. All those in favor of sending House Bill 2358 as amended to full health committee, please signify by saying aye. Any opposed, please say no. The ayes have it. Your bill moves forward.
Thank you, Chairman and Committee.
Thank you. I think we are now on item number 8 on our calendars, also by Chair Lady Carringer. We will call up item number 8, House Bill 2861. We have a motion. We have a second. I believe we've got some amendatory language on this bill as well, Chair Lady. Got
Yes,
drafted
I do.
code 014576. Is that accurate?
Or is it? I've got 014579.
Okay, give us just a moment.
Okay.
All right. All the whispering was about a typo. So we do have a typo on there. On the dashboard, we do have drafting code 14579.
Okay, that's what I have.
We have a motion. We have a second. Now that we got the numbers transposed correctly, Chairman Jernigan seconds the motion. All those in favor of placing House Amendment number 1014579 drafting code on the bill, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. Your bill is now amended. You're recognized for discussion.
Thank you, Chairman and Committee. So this bill comes to us from a constituent who had a bad birthing experience at a hospital. After delivery, she was told by hospital staff that she had to vaccinate her children, and if she didn't, the hospital could call and report her to the Department of Children's Services. And fortunately, this person knew that the law provided medical and religious exemptions, but she brought this to us because of her concern for other people who might not know what the current law says. So as amended, this bill makes it where it's prohibited a medical practice for a healthcare provider to coerce a person to receive a vaccination, represent that state law requires someone to get vaccinated without the option for a religious exemption, or misrepresents that state law requires a newborn to receive a screening test without the option for a religious exemption. A healthcare provider who violates the law in this manner could be subject to disciplinary action by the relevant board that licensed them. And so with that, committee, I'll stand for questions and ask that you will support my bill.
Thank you. Thank you, ladies and gentlemen. You've heard the description. Any questions or comments from committee? Chairman Williams, you're recognized.
Thank you. Just this may be a question for legal, but is coercion, is that clearly defined as to what that would be here in the language or referenced somewhere else in the language? One man's coercion might be another man's suggestion, and I was just wondering.
We will go out of session and recognize legal staff. We are out of session. If you could please tell us who you are and address the question.
Caroline Miller, Office of Legal Services. I'm not seeing coercion defined in the bill. So to the extent that it's not defined, it would be up to a court to decide, but you'd look to the plain and ordinary meaning of the word, like the dictionary definition.
Anything further while we're out of session? All right, thank you very much. We are back in session. All right, Chair Lady Carringer. Thank you. And I think it's appropriate. I've got a piece of legislation that came through this subcommittee and will be in full committee as well, that there are opt-out provisions that are offered to parents in situations like this. And your legislation is making folks aware of that opt-out provision, I do believe. Okay. All right. Chairman Jernigan, you're recognized.
So it's current law. And when you say when you make recognition, is that going to be like a poster on the wall, or is the doctor supposed to say, how are they notified that this is the law, I guess? Or
Do you have an answer to that, Chair Lady Carringer?
Thank you, Representative.
Mhm.
Well, and in the amendment, 14579, or the bill here, in the amendment, it states a healthcare provider shall not coerce a person to receive a vaccination or misrepresent that state law requires a person to receive a vaccination without the option for a religious exemption. So what this particular case was about, a woman that gave birth, and the hospital where she gave birth at, she was not ready to make that decision about what vaccines or whatever to give her newborn child at the time, wanted some time to think about it. But they informed her that if she did not do the vaccines right then, that they could turn her in to DCS.
Okay.
So this is why I'm bringing this bill, to make it clear that they cannot do this. It just happened to be that this particular person knew what the law stood for. So
You recognize Chairman Jernigan.
So basically that doctor broke the law already, right? And you're just codifying it? Is that what? I'm kind of confused on.
You recognize Chair Lady.
So we are bringing this bill to make sure that, to make what our state law says, so that there's no guessing about it. And I mean, still, that doesn't keep anybody from trying to convince someone that they vaccinate their newborn or however. But it's, if they do and they do end up taking them to court, then we've got the law that says.
So this is a, you know that I know that you know that I know that you know that I know. This is what it is. Okay. All right. Thank you, Chairman. Appreciate it.
Thank you. Representative Mitchell, you're recognized.
Yeah, sponsor, do you know what vaccines were recommended?
Chair Lady Carringer.
And no, I do not know. I mean, from being a mom and having 2 children myself, I mean, there are a lot of tests that are done on newborns that you don't realize that are just an automatic that they do unless something, pops up and out of that there's an issue after a child is born. So no, I do not know the specifics of it, but apparently it was pretty significant to bring this to our attention to make sure that there is no questioning in the law that a parent decides not to vaccinate their child, that they're going to be turned over to DCS before they leave the hospital.
You recognize Representative Mitchell.
So this was just at birth. This wasn't the 1 to 2 month series of vaccinations.
You recognize.
Correct.
Okay.
This is just at the time of birth, the 2 days after or 24 hours now that you may come home with your newborn. So sometimes some parents, and particularly new parents, need some time to read and know exactly what all that the vaccines are and that they need. So this is just to give them some time to make that decision.
Any further questions or comments? Chairman Williams, you're recognized.
Thank you. Thank you, Representative. I fully understand what it means to represent your constituents. I do. I'm a little bit concerned about maybe about the definition of coercion a little bit for that. And then also it doesn't clearly define in the amendment that it is within that 24 to 48 hour period. I've supported the bill that this amended, that this is amending last time. So I think what you're doing is correct. I just have some concerns that it's not clear. Comes to mind is a movie where somebody says, I object, and they say, I strenuously object. And so my concern is that it's not clearly defined. I won't be voting for it today if it moves forward, but I would hope that between now and the full committee that you could hopefully kind of clear up those concerns or any confusion that might occur there.
You recognize Chair Lady.
And so just to address any issues on that in terms of, this is directly about newborns after delivery. So we're not talking about 2 months, 4 months, 6 months. So, and to say, I think the whole coerce is about to say, if you don't let us administer the shots or what, at the facility, we're going to turn you into DCS. That right there is pretty alarming, I think, for a parent to, make a decision right then because, I'm going to be turned into DCS if I don't allow this. So again, as far as how many days you stay in the hospital is left up to the, individual. Was it a C-section? There's, as you all know, some could stay less than 24 hours. Some could stay 1 day up to 7 days. So it all depends on the days. It's just a matter of not being told that you don't have time to think about what you think is best for your child, or you're going to be turned into DCS. I don't think any of us would appreciate that. So if we can, I'd love to address your issue. Do you want exactly wording in there that you would, I guess, support. And we can talk about it later. Or
Chairman Williams.
Thank you, Representative. And as I said before, I'm not against your bill. I think it's the right thing to do. I just think for me personally, I would like for it to be more clearly defined. One could argue that 2 months vaccinations after birth is after birth. There's not a time constraint in there. And so I think what you're doing is the right thing. I don't want to slow you down because I'm the guy who's communicating to people, please run your bills. And so, and get these things through. But I do think it could be better clarified. So thank you.
Thank you. Representative Mitchell. Representative Mitchell.
Yeah, thank you, Mr. Chair. My only concern is just reading from what vaccines are required. I hope those same physicians are, when telling them, suggesting that they get these vaccines, are telling them that if you don't get this vaccine, particular the hepatitis B vaccine that can be passed from mother to child at birth, if they don't get that vaccine within 24 hours and the mother unknowingly is passed that on to the child, it's irreversible liver damage is going to be. So I'm hoping they're giving the medical background to why they're suggesting that at the same time.
Thank you. And if I could possibly from the chair try to give a little clarification, I believe, Chair Lady, that your bill essentially says that a medical professional must not misrepresent current law. I don't think it's a question of anything beyond that. I think it's just if there is a misrepresentation of the law that the parents do have an option, that they not be forced into something if they have chosen to opt out, not to have the threat of Department of Children's Services come into their home. So I think, Chair Lady Carringer, you're recognized.
exactly. We're not changing the law per se on what is or vaccines are recommended and all, but it's a matter that these new parents are not being told. These new parents are being told at the hospital that if they don't get these, they'll turn them into DCS when they leave the hospital.
Gotcha. Okay.
And so,
Okay.
yeah,
Thank
just
you.
to make that clear. Yes.
All right. Any further questions or comments? All right. You ready to vote? All those in favor of sending House Bill 2861 as amended to full health committee, please signify by saying aye. Aye. Any opposed, please say no. If you'd like to vote no, please let the clerk know. Your bill passes. Your bill moves forward.
Thank you, Chairman.
Thank you, Chair Lady.
Committee.
And I will continue to apologize. I feel my voice going even as we're talking here. So we're now ready for item number 9 on our calendars. Item number 9 is House Bill 2086 by Chair Lady Helton Haynes. Chair Lady, you have a motion. You have a second.
Thank you, Mr.
You're
Chairman.
recognized. And we've got a couple of amendments. Thank you. We have a couple of amendments. I believe the amendment drafting code that may work is 015039.
That's correct.
All right. Ladies and gentlemen, we have an amendment placed before us, drafting code 015039. We've got a motion. We've got a second. Let's go ahead and get the amendment on the bill for description. All those in favor of placing House Amendment 015039 on the bill, please signify by saying aye. Any opposed, please say no. The ayes have it. Your bill is amended. You're recognized, Lady.
Thank you, Mr. Chairman. House Bill 2086 as amended intends to codify that for-profit entities may not access 340B program in-kind contributions from the state of Tennessee. And that's what the bill does.
Thank you for the brief description. Any questions or comments for the sponsor? Question has been called. All those in favor of sending House Bill 2086 to full health committee as amended, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. Your bill moves forward.
Thank you, Mr. Chairman and committee.
Thank you. We are now looking to item number 10 on our calendar. Chairman Carr, you have a motion and you have a second, sir.
Thank you, Mr. Chairman and committee.
we
I'm
have an
bringing to you
amendment?
today, it's a vape bill. It's a protection bill. Today, this is underage Tennesseans are purchasing vapor products at an alarming rate. And the U.S. and Food Drug Administration data from the last 5 years shows that the vast majority of Tennesseans under age 21 acquire these products. Now, this bill, what it would do, would require that prospective purchasers who, to the reasonable person, appears under the age of 30, provide proof of age as soon as practical upon entering, and require that signage be conspicuously posted stating that entry of those under 21 are prohibited and proof of age may be required, and eliminate vapor products vending machines from the general public access area. Now, if we do this and pass this bill, this will, in Tennessee, will drastically reduce the improper access to the youth and help prevent such devices from negatively impacting the overall health of the state and its learning environment. And with that, Mr. Chairman, there's an explanation of the bill. I stand for any questions, but I do have one witness, if we may, to have him hear them speak today. If it'll be all right.
Thank you. As the sponsor has indicated, if it meets the approval of the committee, would we like to go into recess? We have broad approval. Mr. Danny Gillis is with us, I believe. Mr. Gillis, if you could come up to pick you a chair. Looks like Chairman Cars will get your microphone ready to go. And we are out of session. Mr. Gillis, if you could tell us who you are, who you're with, and what you'd like us to know about the piece of legislation. We're going to have 3 minutes as a timer, and you'll be able to entertain some questions and answers afterwards, but we will stop you at 3 minutes, and then we'll go to questions and answers. So, Mr. Gillis, again, tell us who you are and who you're with, and begin, sir.
I'm the president of the Tennessee Smoke-Free Association, as well as a vape shop owner. My wife and I have 2 stores in Sevier County and 1 in Jefferson County. Our members have stores in just about every district around this wonderful state. Our organization was formed in 2014, and we are actively involved in legislation that revolves around our industry. We represent vape shops that sell non-combustible nicotine vapor products, and we consist of consumers, retailers, vendors, distributors, manufacturers, and like-minded supporters of the vapor industry. Most importantly, we are 100% committed to harm reduction. Many of you have worked with us in the past to advance the efforts of harm reduction by not restricting access to adults. I'd like to stress that vapor products are for adults only. As an organization, we supported raising the age from 18 to 21 here in Tennessee with the T21 bill. We also worked together and supported other legislation throughout the years. But even with these changes, there's still work to be done in our state with youth vaping. We recognize that. Throughout this last year, we have gone throughout our communities and have spoken to our sheriff, our SROs, our police departments, our principals, and of course our state reps and some of our senators about the legislation we're getting ready to put forth here today. And the feedback that we have received about this legislation was overwhelmingly supportive. Many bills have been filed over the years in the name of youth vaping in various and indirect ways from those claiming to be in the vapor industry. There have been efforts to ban flavors, raise taxes, and create burdensome legislation on Tennessee. However, no legislation has ever been introduced until now to directly address how minors are gaining access to these products at the point of sale, and more importantly, how to fix it permanently. As of now, the majority of our vape shops in the Tennessee Smoke-Free Association have already made their stores 21 or over to enter. Unfortunately, this is not true in all cases with most tobacco/vape shops, and it's certainly not the case for public access shops like convenience stores, flea markets, gift shops, and others that sell vapor products across the volunteer state. FDA compliance data from the last 5 years show that over 70% of Tennesseans under the age of 21 acquire these products from illegal sales made at retail locations, which are open to the public at large. So what will this bill do? This bill will require that any outlet that sells vapor products prohibit anyone to enter that is not over 21. You must be 21 to get in. This bill will also require that signage be conspicuously posted stating that the entry of those under 21 are prohibited and proof of age may be required. It also eliminate vapor product vending machines from general access areas.
Okay, thank you, Mr. Gillis, very much. We've hit
Thank
our
you.
time there. Thank you very
Thank you,
much.
sir.
Okay. Questions? Chairman Jernigan,
Well,
you're
I-
recognized.
If you wouldn't mind, I'd like you to finish the comment on that bill part. Thank you.
Mr. Gillis, if you could continue that explanation for a moment.
By limiting the sale of vapor products to stores that only allow entry of those legally able to purchase vapor products, Tennessee will drastically reduce improper access to youth and help prevent such devices from negatively impacting the overall health of our state. We believe that all adults should have the choice to switch from combustible cigarettes to vaping. Our commitment is to continue on that mission while restricting access to youth. And harm reduction is number one for us. Please vote yes.
Okay,
Thank you.
Thank you. Chairman Williams, you recognize. If you could say, Mr. Gillis.
Thank you, Mr. Gillis, for coming today. I just had a clarification. So current practice, what this bill would change, it would change any convenience store that's currently selling these vape products. It would prohibit those businesses from being able to do that going forward. And secondarily, are you grandfathering in the people that are currently doing now, or would they have a period of time where they have to remove all those from their convenience store shelves?
The bill is kind of direct in that we would like to see all vapor products, nicotine vapor products, put in 21 or over specialty vape shops, just for the education alone to know what you're selling, also to keep the minors away from purchasing it. So yes, it would not be allowed to be sold in any other store that is not 21 over. It would remove it from public access areas. It would remove it from convenience stores. It would remove it from gas stations where most of the violations are coming from. Now, we also have tobacco and vape shops, which we don't recommend. We don't work with any of those shops that sell combustible cigarettes. We're strictly vape shops in the nicotine industry. So the answer to your question is yes, it would restrict access in a convenience store and a gas station.
Chairman Williams.
Would completely different element. Would you want to remove alcohol from convenience stores too because it's 21?
Well, I think they've already taken liquor and put it into a 21, pretty much its own establishment for reasons of underage sales and other reasons. But we're actually looking to do something like that. But we're not looking to put any kind of legislation on the state that's going to be a burdensome to the state. We just want to actually say vapor is to be put in a 21 over establishment. You must be 21 over to purchase this product. We know we're finding these in schools. We know we're finding them. I'm talking to all you senators. I'm talking to everybody around the state. We want to fix the problem. And this is 100% going to fix the problem at the point of sale. Is there room for some kind of conversation? Yes. But we feel as an industry, we represent the vapor industry. RJ Reynolds, Altria, they do not represent the vapor industry. The TSFA does. We have shops throughout the whole state, everywhere. We are doing it right. Our tagline is lead by example. We see others that are causing problems for our industry, and we're trying to fix it.
All right. Thank you.
Thank you. Any further questions while we're out of session? Representative Sherrill, you're recognized.
Thank you for being here today. I do support this bill. I think it's very good. My question is, I guess to say, who is going to be there to enforce this?
I think right now, it's a great question. Thank you. I think right now we have mechanisms in place. You're not asking for a special license or anything to sell these products. You're just changing, basically what it has to be a 21 over establishment with signage. So whenever we do the enforcement on the compliance checks right now, you could be doing compliance checks at that as well. And you could put however you guys put your announcements out. So as far as enforcement, we're not asking you to create a task force or do something with this. The current laws that are on the books will enforce this if they do the actual, inspections at the stores. I've been inspected at my store, and my stores, and many of my members have been inspected at the stores throughout the years, multiple times. So the inspections are still being currently put on. I really don't know how Tennessee does their inspections. I know how the FDA does them, and they inspect our stores and convenience stores and tobacco/vape shops, and that's where I'm getting this data from the FDA itself.
Thank you. I do appreciate it. I know we need to somewhere or another keep these out of the hands of our young people because they're not a good thing. But I do appreciate it very much. And
Thank
I
you,
am for the bill.
Chairman Jernigan, you
Thank
recognize?
you. In regard to enforcement, I think it would be just like it would be any other story. If we, maybe the community, we have a tip, we think that that's happening. There's no reason why you couldn't go down to the police department and say you think this is happening, and they can do a sting just like anybody else for violating the law and send someone in that's that's underage to buy. So I think the enforcement part would just be, local law enforcement going in and busting someone for breaking the law, just like they would any other law. So that's my thoughts. Do you disagree or agree with that?
Well, I mean, and to an extent, yes, I agree. However, if you give such a huge pool for these products to be sold across the state, and they could be basically put in any store that has a reseller's license. So if you have a license to be able, tax license, you could sell products in your retail outlet. They can go out and buy from a distributor vapor products put in their store. You guys won't even know who's carrying it. Okay, so as far as inspections and who's got it and where is it at and who's selling the minors, I'm talking to sheriffs, I'm talking to the police officers that are coming in my doors, the school officers in the schools. They're begging for help. They don't know how to fix this problem without it going through you guys. We need legislation that shrinks that pool of where these products are getting accessible at. It's accessible too many places. They took beer and wine, they put them in grocery stores, and they put liquor inside of a specialty store for a reason. And I think I'm not looking for a vape license. I'm just looking for a 21 or over establishment to sell these products, to keep the adults to have the access and keep it away and keep it out of the hands of children. We do not want kids to have this product. I just think it's a straightforward bill. I think we could sit down. If there's a convenience lobbyist that wants to sit down with me, I'd be more than happy to discuss any kind of situation that we might be able to conflict on. But I just think it's about time that we sit and go, hey, listen, legislation has come across you guys' chambers for a long time, many years. I've seen it. I've been in this industry for 10 years. And we've had a lot of bills that have come up in the name of youth vaping, and it had nothing to do with addressing the problem of youth vaping. It was about banning flavors, putting taxes on it.
I understand that. And Chairman.
Chairman Jernigan.
I was just trying to answer Representative Sherrill's question that there is an enforcement mechanism in order to do this, and that would be appropriate. I agree that in my high school, the high schools, there's too much of it.
Yeah.
And if we can listen, I'm all about going to the source. So thank you, Chairman.
Thank you. And Mr. Gillis, I will tell you, and you and I have spoken a couple of times last year and this year as well, and you know that I have been involved in trying to address this issue. Last year, my thought is to come back next year with a piece of legislation as well that would call for a universal carding within any establishment that might sell these products. I do understand where we're coming from on this particular piece of legislation. It's quite aggressive, as you and I had the conversation. It's quite aggressive. I'm wondering if there can be some type of middle ground out there where we can get in, to create a universal carding possibility. Do you have any thoughts on that, sir?
Well, I think we use scanners. So we have a scanner system, whether it's tied to the database of local law enforcement or not. I've had some scanners that have come in recently. I've scanned some Georgia IDs at my Pigeon Forge location, and they've come back as a fake ID. We tell them we can't give you back your ID and you must leave. Well, we've called the police several times, and a couple of times those IDs were actually real, and a couple of times they were not. So I'm for an ID always. I don't know if you're necessarily going to get everybody to follow that, though. If you can say, are you using an ID scanner at this store and this store or this store, you're actually still, it's the enforcement of it. It's such a large pool. So I think, I would just say the pool needs to, and I'm not picking winners or losers here. Okay. This is not about money. This is about access to kids, but I think it needs to be shrunk down to those who are responsible, and then let Tennessee find the hell out of us if we are breaking, or those are breaking the 21 over law and selling to minors. We accept that legislation. We accept those kind of, hey, you're going to get a fine. You're going to get, lose your license. We expect things like that, So I think if you keep that, age ID across the board, I still think you're gonna have bad actors all over the place. It's just as bad as it is now, where the products are being sold all over the place.
Yeah.
It's hard to enforce.
And I have seen enforcement in my district in particular. There were four shops that were cited recently in a sting, much like what Chairman Jernigan had said. As I'm listening to the conversation, I do feel that there may be winners and losers that may be set up by this particular piece of legislation. Thank you very much. Any further questions or comments for Mr. Gillis while he's with us? Thank you very much, sir. Without objection, we will go back into session.
Mr. Chairman,
Yes,
if I
sir.
may, I think that I made a big goof. I did explain the bill, but I think I have an amendment that makes the bill 14788.
That's as much my goof as it is yours, Chairman Carr. Normally we get those amendments on as we begin, but in my excitement to hear this conversation, it went. We got a motion and a second on adopting amendment drafting code 014788. All those in favor of placing amendment drafting code 014788 on the bill, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. Your bill is amended. You're recognized, Representative Chairman Carr.
Thank you, Mr. Chairman. And we all know and realize around here, sometimes when we bring something forward to a committee, it is therefore for the conversation. And I think this is what this is for. And I think that we can all see that we all have problems with this. And I appreciate the indulgence of this committee to listen to this. I have had children on school buses that have had to be, the bus drivers had to stop his route, take them to the emergency room before they could even finish their route on that. And I know there's always a conversation, and I look forward to having this conversation again. I may not be here, but somebody will follow on through with this. And I was just notified that this was general subbed in the Senate over there. So with your indulgence, and I do thank you once again for listening to this, because I think you all know that we have a problem with this. And with that, Mr. Chairman, I'd like to take this off notice.
Thank you. And I will make a few comments. And Mr. Gillis and your industry and everyone who's called and communicated with each of us, I see there's tremendous value. And Chairman Carr, we will take up the challenge that you've given to us as a legislature, those of us coming back that hope to come back. I think we can take up the challenge of this. And ultimately, we want to keep these products out of the hands of minors. And it's getting into our schools. Our Sessions Court and juvenile judges are having tremendous issues with this, as well as our school resource officers. Many of our schools are equipped with sensors right now that are sensing these products being in our schools, and they are being located by the thousands across the state of Tennessee. I see great value in this legislation, and I want to work with all those, the vape industry and all those involved to come up with a solution for this issue. As we talk about solutions, it's not always something that we love, but something we can live with.
Exactly.
And that's what we're looking for. Did I hear the request to take the bill off notice, sir?
Yes, sir, you did.
Okay. Without objection, House Bill 2539, although with a minor groan to my right, House Bill 2539 taken off notice.
Thank you, Chairman and committee.
Thank you. We are now on item number 11 on our calendars, House Bill 1846 by Chairman Clemens. Chairman Clemens, you're recognized. You have a motion. You have a second. You're recognized, sir. Do you
I've
have
got
any-
an amendment that makes the bill. It's barcode 014521.
You have a motion. You have a second on the amendment drafting code 014521. Let's go ahead and place it on the bill if we could. All those in favor of placing amendment drafting code 014521 on the bill, please signify by saying aye. Any opposed, please say no. The ayes have it. You're recognized.
Thank you, Mr. Chairman and committee. It's an honor to be before you today. This bill would simply require the Department of Health to submit an annual report to the governor detailing the total number of firearm injuries and deaths, as well as certain demographic information caused by firearms in this state per 100,000 people that occurred in the previous calendar year. It required the Department of Health to ensure the confidentiality of the individually identifiable health information, that is protected in the process. And the Attorney General and reporter would assist in collecting this information to the extent necessary. And that is the the entire bill, Mr. Chairman.
Thank you, Chairman Clemens. Questions or comments? Chairman Williams is recognized.
Thank you, Chairman Clemens. Does this does the TBI not collect this data already? It would be the Department of Health through, I guess, death certificate data. Would that be the difference?
Yeah, so TBI only gets it based on what's reported to some extent in various ways. So recently, the Sycamore Institute, for instance, did a statistical deep dive on this to produce some information, and they had to go through each county's death certificates. Then they had to pull TBI information and pull it all together in one. So there's no one collective agency that contains this data. Now, the Centers for Disease Control and Prevention's National Center for Health Statistics publishes some of this data. But I mean, if we have Tennessee specific, I think it would be more helpful to be a central location for all that data to be used and relied upon in forming policy.
Recognize Chairman Williams.
I was not aware of the CDC created that data, but in the acquisition of that data, do they have the ability? They don't have the ability to narrow that data per state, or they just do it. I don't know how they would do it without getting it per state data.
Well, it's kind of the same reason that it's so difficult for a state-based, think tank to do it, where they had to go and collect all the death warrants from each county, to combine that with the TBI and how it was reported and so forth. So, so it would be beneficial to have a centralized state-based agency do it, just for the purposes of us being at and getting that report. There's, nobody has to give us anything at this moment.
Right. Thank you.
Thank you. Any further questions or comments? Chairman Leatherwood, you're recognized.
I think I heard you in your comments saying some demographic information would also be gathered.
Yeah.
Curious what demographic information would be collected. And I do, like you say, the confidentiality of that would be maintained, but curious what demographic information.
Yeah, so the demographic information could be based on young, old, white, black, Latino, Hispanic, urban, rural. It could be any number of things. Demographics can include sex, religion, any number of things based on the demographics. So those types of things are useful in the collection of data for the purposes of forming policy and using evidence-based approaches to this. So, even if you're a veteran, that would be an example. And this requires data to be collected from firearm injuries that one inflicts upon themselves. So even collecting suicide information, if we want to know how many veterans are suffering from mental health issues and leading to suicide, those types of things.
You recognize Chairman Leatherwood.
And you kind of touched on another aspect of my question. Would this also, you say, include suicides, but would it also classify the type of violence that was going on? Was it, accidental shooting, self-inflicted shooting? Was it a robbery or so? Would it give that information as well?
Yeah, so in subsection B of section 1, it lays out what the reports must include at a minimum, if available. That includes the county in which each injury or death occurred, the demographic information, who suffered a firearm injury or death of any type, the cause of each injury or death as indicated in the death certificate, police report, or other official document.
Chairman Williams.
Sorry, another question. Would it also include the data as it relates to the type of firearm?
That is not set forth in this. This simply says the number of firearm injuries and deaths. So it doesn't specify as to what type of firearm.
Thank you.
Thank you. And Chairman Clemens, this is a report that will go to the governor, correct? The data will be collected by the Department of Health, and the report will go to the governor, correct?
It would go to the governor, chairman, and again, the Department of Health shall ensure that the information reported pursuant to this is in accordance with applicable state and federal laws to maintain the confidentiality of any individually identifiable health information.
Okay. Thank you for that clarification. Further questions or comments for the sponsor? Seeing none, are you ready to vote? All those in favor of sending House Bill 1846 to full health committee as amended, please signify by saying aye. Any opposed, please say no. If you'd like to vote no, please let the clerk know. Your bill passes. Your bill moves forward.
Thank you, Mr. Chairman and Committee.
Thank you. All right, we are now ready for item number 12 on our calendars. Patiently waiting is Representative Chairman Wright. Chairman Wright, we're on item number 12. House Bill 2261 is called up. You have a motion, you have a second. You're recognized, sir, and I think, do we have your bill seems to be straightforward with no amendments, sir. Is that correct?
That's correct, Mr. Chairman. Thanks, Mr. Chairman Committee, for entertaining my bill, which I will enduringly call the Golden Girls Bill. My intention here is to establish a class of licensure for 1, 2, or 3 unrelated mature people to live in the same residence for relatively permanent and domiciliary, what a word, care. And with that, let me stand for questions.
All right, you've heard a brief explanation from Chairman Wright. Any questions or comments for the sponsor? I will say you have worked in this space with Senator Massey for a couple of years now.
That's correct.
I think this has been a bill that has been close to you and many of the Golden Girls across the state of Tennessee. Is that an accurate statement?
Yes, Mr. Chairman.
Thank you. Are you ready to vote? Question has been called. All those in favor of sending House Bill 2261 to full health committee, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. Your bill moves forward.
Thank you, Mr. Chairman Committee.
Thank you. And I believe that you will be taking forth item number 13, which is a Senate Joint Resolution number 918. Do we have a motion? We have a second. You're seconded. You are recognized for explanation of Senate Joint Resolution 918, sir.
And again, thank you, Mr. Chairman and Committee. Senator Massey has brought with me a resolution that, let me look at the back end of it, or the end of it, the where be it resolved part, and say that as a means of reducing Tennessee's suicide rate among veterans and providing veterans a resource for recovery from substance abuse, mental illness, or co-occurring disorders stemming from their military service, we urge and support the creation and implementation of a state-certified peer recovery program to serve Tennessee veterans and active service members. This resolution to be forwarded to the governor, the Commissioner of Veterans Affairs, and the Commissioner of Mental Health and Substance Abuse. I'm a veteran. I proudly and would not back up on the day of serving the 3 years that I served in the military early on in my life, because it made a change in my life. Nothing, I want you to recognize that there are other members that have served, that the change was significant in their life, but in a detrimental way. What this resolution, if you read the whereases, would point out that there are peer groups of veterans to help veterans, and we need to take better advantage of that in helping our veteran population here in the state of Tennessee, and therefore ask for your support on this resolution.
Thank you, Chairman Wright. Any questions or comments on the resolution? Question's been called. All those in favor of sending SJR 918 to full health committee, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. Your resolution moves forward.
Most deeply, I appreciate your all's work. Thank you, Mr. Chairman and Committee.
And Chairman Wright, thank you, and thank you for your service. I'd seen Chairman Travis in the crowd. Yes, there is Chairman Travis. Item number 14 is House Joint Resolution 820. You have a motion and you have a second. Representative Travis, you're recognized for explanation, sir.
Thank you, Mr. Chairman and committee. And I am surprised you're still talking with that hoarse voice of yours. I'm telling you, you got to be holding on. This is a HJR 0820, and it's for who? It's for the World Health Organization. You've seen it in the news. It's all the scandals that's happening now is unbelievable. The Ebola outbreak in 2018 with the members have been with the sexual partners with the people of Congo. So it's just gotten out of hand. And this resolution only calls for the elected U.S. representatives and senators representing the state of Tennessee to take all steps necessary and reasonable to end the taxpayers' funding of the World Health Organization.
Thank you, Representative Travis. You've heard the explanation. Any questions or comments on the bill? Question has been called without objection. All those in favor of sending House Joint Resolution 820 to full health committee, please signify by saying aye. Aye. Any opposed, please say no.
Thank
The
you.
ayes have it. Your bill moves forward, or
Thank you, Mr.
resolution moves
Chairman.
forward.
Thank you, and to the committee, thank you.
Thank you. We are now ready for item number 15 on our calendars. Item number 15 is House Bill 2664 by Representative Slater. You have a motion. You have a second. You're recognized, sir.
Thank you, Chairman. Thank you, committee.
I think we do have
There is an
some
amendment on the bill, yes.
Yes, we have some amendatory language that will rewrite the bill. I'm seeing drafting code 014989.
That is correct, yes.
You have a motion. You have a second. All those in favor of placing amendment drafting code 014989 on the bill, please signify by saying aye. Aye. Any opposed, please say no. Your bill is amended and ready for explanation, sir. You're recognized.
Thank you, Mr. Chairman. And as amended, this bill requires Tennessee schools to post notice, either in writing or on the school's website, that any student vaccination requirement imposed by the school are subject to a medical or religious exemption under current law. They are also required to provide parents with a copy of a form written statement that the parent can file with the school to obtain a religious exemption under the law. Schools in Tennessee will be required to start providing this information in the upcoming 24-25 school year. With that, I stand ready for questions.
Question.
All right. You've heard the explanation. Questions? Chairman Jernigan, you're recognized.
Thank you, sponsored. So can the form just be downloadable on the website? Like you just go to the website and download the form? Or do they have to physically present something to you? Or
Thank you, and thank you for that question. I believe that would be subject to any rules that would be promulgated, but I would suspect that it would be a downloadable form that they could submit.
Thank you for that question. I'll recognize that we do have my 12-year-old daughter up here, and the time frame between my 23-year-old daughter and now my 12-year-old daughter, we used to get all these files full of paper documents that we had to look at and sign the first day of school or not sign the first day of school. And now everything is downloadable and online, and information is getting to parents in many different ways. So thank you for that. Any questions or further comments for the sponsor? You ready to vote? All those in favor of sending House Bill 2664 as amended to full health committee, please signify by saying aye. Aye. Any opposed, please say no. If you'd like to vote no, please let the clerk know. Your bill has the votes to pass. Your bill moves forward, sir.
Thank you, Chairman. Thank you, committee.
Thank you. House Bill 2664 moves forward to full health committee. We're now ready for item number 16 on our calendar. The moment you've all been waiting for, ladies and gentlemen. We are ready to call up House Bill 1146 by Representative Vital. You have a motion. You have a second. I think we have some amendatory language, sir.
Thank you, Mr. Chairman. Thank you, members of the committee. We do have an amendment, drafting code 014280.
That's the amendment that we have. Let's go ahead and get the amendment on the bill so we can discuss in full throat, which I don't have. All those in favor of placing House Amendment Number 1, drafting code 014280 on the bill, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. Your bill is ready for discussion as amended, sir.
Thank you, Mr. Chairman. Thank you, members. This legislation will create a new pathway to provide quality health care to patients across Tennessee. Tennessee, like many states, is facing a severe workforce shortage with healthcare providers, which results in delayed or canceled surgical procedures, longer wait times for critical care, and needed and increased financial strain on medical providers as facilities remain underutilized. Certified anesthesiologist assistants are medical professionals who work under the direct supervision of an anesthesiologist to assist with anesthesia care during the medical procedure. Currently, AAs are not allowed to practice in Tennessee and must go to neighboring states to work. Tennessee is a welcoming state. Border states that allow AAs to practice are North Carolina, South Carolina, Georgia, Alabama, Missouri, and Kentucky, although Kentucky requires AAs to have a PA license, and all VA facilities. Allowing AAs to practice in Tennessee will increase the pool of available healthcare providers to assist with much-needed patient care. AAs have practiced in the United States for over 50 years and are licensed in 20 different jurisdictions. House Bill 1146 simply allows for AAs to be licensed in Tennessee. This will increase the availability of quality patient care for Tennesseans and will allow healthcare professionals to live and work in Tennessee without having to drive to a border state, which allows for licensure. With that, Mr. Chairman, I am ready for questions, and we do have witnesses.
Thank you very much, Representative Idle. Any questions? We do have a request to go out of session and hear from several folks today. Any questions before we go out of session? Okay. With no objection, we will go out of session. We have several folks that would like to speak. We have Kelly Ray, who is with the Tennessee Academy of Anesthesiologist Assistants. And we have Dr. Jonathan Hughes, who is with the Tennessee Society of Anesthesiologists. If those folks could come forward. If you're ready to present to us. All right. And as you get seated, I will, if you've been in the committee for the last few minutes, you'll recognize that what we ask of you is to tell us who you are, who you're with, and what you'd like us to know. It will be 3 minutes during testimony. We have Ms. Ray. Will you please raise your hand? Okay, Ms. Ray. And Dr. Hughes. No Dr. Hughes. So we've got you guys on our list. Whichever would like to begin the conversation. Dr. Hughes, if you again tell us who you are, who you're with, and what you'd like us to know. We'll do 3 minutes and then have time for Q&A after that. You're recognized, sir.
Committee. My name is Jonathan Hughes. I'm a medical doctor and anesthesiologist practicing in the Tri-Cities of Tennessee. Let me begin by saying that I work with a fantastic group of nurse anesthetists and anesthesiologists in my practice in Northeast Tennessee. It is neither my position nor the position of the anesthesiologist in this state that this bill is in any way intended to be anti-CRNA. The anesthesia professionals with which I work are dedicated to providing essential care to our communities daily, and I greatly value their contributions. And virtually all anesthesiologists with which I have spoken throughout the state have shared this sentiment with me and wanted me to share it with this committee. However, we are facing unprecedented demand for anesthesia services throughout the state, and we do not have enough anesthesia professionals to meet this rising demand. In preparing to be here, I've reached out to colleagues across the state to inquire about their experiences. I've heard from groups in Memphis, Cookeville, Jackson, Nashville, Chattanooga, and Knoxville, to name a few. Vacancy rates in these groups ranged from 12% to more than 35%, with not a single respondent reporting that they are without staffing shortages, and my practice in Tri-Cities is no exception. What this means for daily operations is closed operating rooms, delays in surgery, utilization of temporary contract workers. In my practice, we've experienced a wide variability in the quality of care provided by these temporary workers, and we would much prefer individuals who are not transient but contributed meaningfully to our communities, both in and out of the operating theater. Excuse me. This shortage has also led to current anesthesia professionals working well beyond contracted hours and shifts, leading to further burnout and loss of team members, exacerbating the shortage. Certified anesthesiologist assistants, or CAAs, would provide another labor pool of anesthesia professionals to help ease the struggles in Tennessee, just as they do in various other states throughout the country. You may have heard a better answer to our shortage would be expanding enrollment in existing CRNA training programs. Why not do both? One concern that has been voiced is that adding CAA licensure to our state would limit training opportunities for student nurse anesthetists. In my practice, we have approximately 40 anesthetizing locations per day, operating rooms, endo suites, etc. We have 3 to 8 students working clinically daily, leaving over 30 rooms in which there are optional educational opportunities. I also, in hearing from other practices throughout the state, they responded they had anywhere from 30 to over 150 ORs available for further student training daily. Even with the addition of CAAs, there seems to be plenty of capacity for further growth of our educational programs. So while expanding our CRNA training programs, why not open the doors to CAAs as well to join us and help? Licensure of CAAs might not benefit every geographic area of Tennessee and might not fit the practice model or culture of every anesthesia practice in our state. But if there are CAAs that want to work in our state, and if there are hospitals and practices that could benefit from their service, shouldn't they have the liberty to choose, particularly given our dire workforce shortages? I personally believe there's more than enough work today and for years to come for both professions to exist in our state, just as they do in North Carolina, Georgia, Alabama, Florida, and many other states. Thank you for the opportunity to speak.
Thank you. Thank you very much, Dr. Hughes. Ms. Ray, if you'd like to speak again, please tell us who you are, who you're with, and 3 minutes. We'll begin when you begin.
Good afternoon, Chairman Crow and members of the committee. Thank you for allowing
I
me
will let you know this is not the Senate. So,
good afternoon, Chairman Hogg and members
Thank
of the
you.
committee. Sorry about that. Thank you for allowing me to speak to you today. My name is Kelly Ray, and I'm a certified anesthesiologist assistant in strong support of HB 1146. I'm president of the Tennessee Academy of Anesthesiologist Assistants and here today to represent the many CAAs from Tennessee that want to return home to their families to work in this great state, as well as others that would love the opportunity to move here. I received my undergraduate degree in biochemistry pre-med in Tennessee at Lee University, where I met my husband, who is also a native Tennessean, and he still works in Tennessee. I then attended Emory University School of Medicine to obtain a Master of Medical Science and Anesthesiology degree. I have been practicing as a CAA for 7 years in Georgia, where CAAs have been licensed for more than 50 years. We are not a new profession and are currently allowed to work in the majority of states that border Tennessee by providing quality anesthesia care to patients every day. We are a safe, effective, and qualified solution to the anesthesia shortage that Tennessee is facing. Other medical specialties in this state are allowed to work with both nurse practitioners and physician assistants. Anesthesiologists and hospitals should have the option to operate with both CRNAs and CAAs as well. CAAs provide safe anesthesia care in some of the leading hospitals in our country, including Emory and the Cleveland Clinic. A 2018 study by Stanford Medical School compared CAAs and CRNAs working in the anesthesia care team and found no significant difference in mortality, length of stay, or spending between the two providers. I have the same job responsibilities, the same salary, and the same benefits as my CRNA colleagues, and we work together cohesively every day. I have worked side by side with CRNAs for 7 years in a friendly work environment. This legislation is not intended to choose one type of anesthetist over another, but instead to create an additional professional healthcare licensure pathway where we both can be utilized to provide anesthesia services. Please support HB 1146 because CAAs are highly trained providers and ready to move our families back to Tennessee. Thank you.
Thank you. Questions and comments for our presenters? And forgive me, Ma'am, we don't have your name on the list.
Okay, I was Jennifer Stever.
Jennifer Stever?
Yes, sir.
Okay, let us continue to check.
Okay.
While we're in a pause here, any questions or comments for the two individuals who have presented so far? I will ask a couple of questions if I could. For Ms. Ray, tell me what is your background? Did you begin in a medical path, and what was your training to get into the AA role that you have now?
Starting college, I wasn't sure if that would be being a PT, a PA, going to medical school. So I decided to major in biochemistry pre-med. And my senior year, I came across the anesthesiologist assistant program, and I shadowed in the OR and fell in love with the career. So from there, that's whenever I went to Emory University to obtain the master's in medical science and anesthesiology degree. In order to get into the program, it's the same requirements that are required to get into PA school or med school. You have to take the GRE or the MCAT. In school, we obtain more than 2,500 clinical hours and 600 anesthetics before graduation. And we're also required to take a national certification exam in order to graduate, and also a recertification exam every 10 years, as well as 50 continuing medical education hours every 2 years in order to maintain certification.
You sound very acclaimed, and congratulations. Is that common for your colleagues that work as AAs in Georgia? Do they have similar backgrounds, or do they come from other realms of study and then go into the AA field?
Yes, sir. All applicants to any AA program have to meet those same prerequisites that, like I mentioned, are required for physician assistant programs, biochemistry, organic chemistry, general chemistry, medical terminology, things like that, of that nature.
Okay, sounds good. Were you able to do your schooling in Tennessee? Is there a program in Tennessee that can train individuals for these AA positions, or were you out of state whenever you took your training?
Yes, I completed my training in Georgia at Emory University School of Medicine. There are 20 AA programs across the country, and all of them are affiliated with schools of medicine.
Okay. So how quickly could a Tennessee teaching school ramp up and create this curriculum for the position? And you may not be aware of that. That may be a question for someone else.
Well, as far as meeting the staffing shortage goes, there are many AAs that are currently practicing around the country that either are from Tennessee or went to school in Tennessee, or just simply would like the opportunity to move here. So we would be available to meet this shortage very quickly. As far as how long it would take to start a program in Tennessee, I think Dr. Hughes can better answer that question.
Thank you. And I'll switch that one to you, Dr. Hughes. Let you take a swing at that, and then a couple more questions.
From the cuff, but they recently opened a program in Wisconsin, and I do know the individual involved in that, and it took them about 18 months from the approval of the school to putting the first class in place. And of course, it's 2 years of training. So that would be 18 plus 24. So it took about 30 to 42 months, if I'm doing that math correctly, to graduate the first class. But that was Wisconsin.
Okay. Thank you very much, Dr. Hughes. Appreciate that. Can you tell us as well, Dr. Hughes, tell me what the ratios are for, or would be under this piece of legislation for you to supervise? What would the ratios be for you in the supervisory role?
So in anesthesia, the roles, the ratios that are created are simply created by the billing, the insurance company, which is mostly CMS. So medical direction limits an anesthesiologist to supervising no more than 4 rooms with any qualified anesthesia provider. AAs only work under a medical direction model, so that would be a 4-to-1 ratio. That, to my knowledge, is the predominant in the state of Tennessee, where there are anesthesiologists, is the predominant method of practice that people use medical direction where there are anesthesiologists.
Gotcha. And we are tasked with what if scenarios and just going down that road. What if an emergency happens in the 4 rooms that are in the hospital, and an emergency happens in one room, and you or others are taken away from the supervisory role there? Can you walk me through an emergency while you're supervising 3 others?
Sure. So that could occur in today's scenario. So if I'm on call on a Saturday and I'm the only physician in-house and we're running 4 operating rooms, then that scenario can occur. And as physicians, we have to determine where we can be best utilized. We have to triage those situations. At other times throughout the day, now, if it was a big disaster, such as, like my partners used to say, a bus full of hemophiliacs gets in a car wreck, in my practice, in most practices, we have second and third docs on call. So I would call in another anesthesiologist, and we would activate emergency pathways through that. But that's the current practice environment in which I work now. The most common scenario is something on obstetrical, on OB. So in our practice, we keep someone has to be available for OB as well. So
Thank you very much. Thank y'all. Any further questions or comments? I thank y'all very much. We appreciate you coming forward. Thank you. We also have, at the bottom of my list here, we have a couple of folks who would like to speak as well. We have Christopher Hewlin and Jordan Hollingshed. I think we're both with the Tennessee Association of Nurse Anesthetists, if I'm accurate in that depiction. If you could come forward, and much like we just saw, if you could make sure the red light is on in front of you. And whoever would like to go first, we have Christopher Hewlin and Jordan Hollingshed. Whoever would like to go first, you recognize. Tell us who you are, who you're with, and what you'd like us to know.
Just want to make sure I'm on the list. Hope Ferguson.
I'm sorry. What's your name? Forgive me, Miss Ferguson. We also have Hope Ferguson is also on the list, so forgive me. Hope Ferguson is on the list as well. So whomever would like to begin, please start.
Thank you, Chairman. My name is Hope Ferguson, and I'm the current president of the Tennessee Association of Nurse Anesthetists. I'm a CRNA, a veteran, and a nurse anesthesia educator. I'm here today on behalf of more than 2,500 CRNA and SRNA members whose priority is providing safe anesthesia services to patients across the state in rural and urban areas alike. HB 1146 was brought under the pretense of addressing healthcare shortages and expanding practice providers available in the state. So how does AA licensure solve these issues? In short, it doesn't. This bill was not brought as a result of studies, stakeholder input, or evidence-based data based on Tennessee needs to address anesthesia shortages. It was brought as part of a national effort to expand AAs by physician anesthesiologists. It's worth noting that similar efforts have failed in Virginia, Arkansas, and Mississippi. AAs have not demonstrated the ability to scale to address shortages in any state neighboring Tennessee outside of Georgia where they were created. Alabama passed licensures in 1995. They have 19 AAs. North Carolina in 2007, they have 39. Kentucky has 0. South Carolina in 2001, they only have 40 AAs. But even with 36% of the AAs in the country, Georgia still ranks behind Tennessee in the number of providers per population. AAs can't address shortages or expand access in rural areas or address shortages in urban facilities with anesthesiologist shortages. AAs are required to practice under direct supervision of a physician anesthesiologist. So where there is no anesthesiologist, there is no AA. CRNAs, unlike AAs, are not tied by medical direction to a physician anesthesiologist and therefore can provide anesthesia services to patients in rural communities. Currently, CRNAs are the primary providers of anesthesia services in rural counties throughout Tennessee. This bill will negatively impact clinical opportunities for our SRNAs and Tennessee nurse anesthesia programs. Tennessee has 7 nationally accredited doctorate level nurse anesthesia programs, which my colleagues will expound upon. But beyond what the effects of this bill will be or will not be, TANA also wants to highlight significant issues with the bill as proposed that must be addressed to ensure patient safety as well as transparency. First, the definition of supervision is vague as drafted. AA should only be able to function under direct supervision of a physician anesthesiologist, not merely defined as the availability of a physician anesthesiologist who can delegate, coordinate, direct, consult, or oversee the implementation of the physician anesthesiologist's intentions. In addition, immediately available and what it means for a physician to intervene are not defined. Further, the bill specifies that the supervising physician may supervise AAs in a manner consistent with federal rules or regulations for anesthesia reimbursement. We believe that using may rather than shall could mean that they would not have to comply with federal TERFA supervision ratios. The scope of practice in the bill for AAs is excessively broad, going beyond the standards and guidelines for AAs. In addition, we would also raise concerns around the ability of an AA and obtain prescription drugs per the physician's direction, which is.
Thank you, Ms. Ferguson. We've hit a wall there. Thank you so much. Whoever would like to be next?
Good afternoon, Chairman Hawk and members. My name is Chris Hewlin, and I'm a CRNA, a nurse anesthesia educator, and a former hospital administrator. As legislators, many of you approach issues the same way that we as healthcare providers do, by asking questions to identify the problem, assess treatment options, and identify solutions that provide a benefit while doing no harm. Over and over, we're hearing from proponents for this bill that there are not enough anesthesiologists or CRNAs. They're overworked and stretched thin. Hospitals and facilities need help. Urgency demands action, right? So what is the urgency? That should be the first question. I want to share with you the answer to that question. The bill benefits one anesthesia provider, physician anesthesiologist, and anesthesia groups that want to entrench the medical direction reimbursement model with a strict 1-to-4 ratio. Anesthesiology assistants derive their authority to practice via medical delegation from a physician anesthesiologist, can only function under one type of anesthesia staffing model, the medical direction. Medical direction requires the 1-to-4 ratio, where they can supervise up to 4 AAs with strict compliance requirements, making this an expensive anesthesia staffing model that has not proven to improve patient safety or increase access. The medical direction model secures a physician anesthesiologist employment payment paid for by the hospital subsidies to the anesthesia group. This bill creates barriers for hospitals who may wish to change to a more efficient model in the future. CMS billing information charts show where the trend is headed and why this bill is being pushed with such urgency. In Tennessee and across the country, percentage of QZ anesthesia billing is growing, meaning CRNAs are billing in either independent or a collaborative model. The 2 highest cost models, anesthesiologists only or 1-to-4 medical direction with supervision from anesthesiologists, are on the decline across the country. The 1-to-4 medical direction model is the only model where AAs can function. This is also the reason they can't work in rural Tennessee, small surgery centers, office-based practices, basically anywhere there's not enough money to support a 1-to-4 model. Anesthesiologists and their national organization are working hard to stop this downward trend. Thus, the national push for AA licensures, because the first AA that enters a facility entrenches that 1-to-4 model and prevents a more cost-effective model from being utilized. In other words, this bill is about AAs protecting the costly medical direction model, securing physician anesthesiologist jobs in a model that has 20% of the workforce watching somebody else do their job. So now that we have answered the question about the why, let's talk about the other important issues that are not being asked or answered by this bill. There have been no questions asked or answered about efforts by hospitals and anesthesiologist groups to actually evaluate and assess what's causing the problem. What is the data on CRNA shortages and anesthesiologist shortages? Are there practice issues in the environment? There have been no questions asked or answered as to what hospitals or anesthesia groups they contract with to provide anesthesia have done to increase CRNA recruitment and retention.
Thank you, Mr. Hewlin. We are up
Yes, sir.
against
Thank
time.
you for the opportunity to speak.
We are up against time. We had 2 individuals speak earlier. We're going to have 2 individuals speak now. So I'm going to cut off conversation. We do have time for questions and answers. So anyone have any questions of the presenters? I do want to know and ask the question, and Ms. Hollingshead, you may be able to answer this. I will ask questions of the education behind an AA. Can someone please define for me the education of a CRNA? And if you could, since you've not spoken yet, if you could tell us who you are and who you're with and address if you like.
Yes, my name is Jordan Hollenshed. I am a CRNA practicing in Middle Tennessee, and I am with TANA. Yes, so in order to become a CRNA, you first have to go to nursing school. So you get your undergraduate in nursing. And then after that, you have to work in an intensive care unit for at least 2 years. I believe the national average, according to the American Association of Nurse Anesthetists, currently is people are working in the ICU for 7 years prior to going back to CRNA school. Once you are in CRNA school, it is a 3-year program, and you have now obtained your doctorate. So out of those 3 years, you do over 2,000 cases in around 3,000 clinical hours.
Thank you very much. Any further questions or comments for our presenters? Saying that, thank you very much. We appreciate you all. All right. I think many of the folks in the room would like to get to a vote on this. So without objection, we will go back in session. Representative Vital, you're recognized to tell us more what you'd like us to know, sir. You're recognized.
Thank you, Mr. Chairman. Thank you, members, for hearing the testimony. I would just say this is about patience and the opportunity to provide more opportunities for surgeries in Tennessee. Thank you. And I ask for affirmative vote.
Thank you. Representative Vital, I will ask a question, and I've, this being not my first rodeo, I have a concern of scope of practice, and I know there's no CMS billing at the moment for AAs, but I'm wondering, be careful what you ask for, you just may get it type situation where we have scope of practice issues that come up on a regular basis. And I'm wondering if this would create 10 years down the road, if CMS does have a reimbursement to our AAs, if this creates a scope of practice issue where the anesthesiologists are in conflict with our AAs in the not too distant future. You have any thoughts on that, sir? And maybe that may have been a question while we're out of session, but I'll certainly ask you as the sponsor.
Thank you, Mr. Chairman. I would say I can't predict what the future will bring, but I think it's something we will all have to watch together as this committee and members of the legislature.
Okay. Thank you very much. Any further questions or comments? We're about to be told we got to get out of here. So are you ready to vote? All right. All those in favor of sending House Bill 1146 to full health committee as amended, please signify by saying aye. Any opposed, please say no. No. If you'd like to be recorded as a no, please let the clerk know. Your bill moves forward.
Thank you, members of the committee, and thank you, Mr. Chairman. Appreciate it.
Thank you. Ladies and gentlemen, thank you for your patience on this particular issue. We are adjourned. Forgive me.
All remaining bills rolled to the next.
Forgive me, a little too early on that adjournment. All remaining bills will be rolled to the next calendar. Once again, all the bills that were not taken up on this particular calendar will be rolled to next week. Seeing no objection, we are adjourned. I'm a no. Who all said no?